Okay, I'll get started, and then if anyone else arrives, then that's fine. So, I'm Rebecca. I'm the Orthopy president. I'm the person who's been sending those annoying messages into the group chat. Hopefully you'll remember me from the Lab Med course last year. I've put these two sessions together, the chest X-ray and ECG, because they rarely come separately when you actually see them in real life, especially when a patient comes in for the first time into ED. You're never just going to get one without the other. Especially for our OSCEs last year, the data interpretation station was mixed. So an ECG that you had to interpret, followed by a chest X-ray that you had to interpret, followed by trying to come up with a unifying diagnosis that would make the two make sense together. So the structures and indications are pretty much the same. So it's good to start thinking of them as two sides of the same coin as soon as possible, basically. I'll be rattling through really quickly. We've got 90 minutes. I've made every effort to make the slides into the best kind of revision resource possible on their own. So the best thing you can do is practice with them in your own time. It will give you a really clear structure and really clear things to look for. But yeah, I'll talk you through it quickly. There won't be any multiple choice questions, but there will be questions where it's time for you to sit and think about what you would say, because this is very much OSCE content rather than MCQ content. So yeah, it's going to be a bit of a whistle-stop tour. If anyone has any questions, please just either put your hand up or unmute and let me know. I'm happy to be stopped and quizzed. Right, let's get cracking. Cool. Okay, so we'll start with ECGs and then we'll move on. So we're going to learn to use a structured approach, identify abnormalities, and recognize common patterns of abnormal ECGs. Just really quickly, you'll hopefully remember this is a normal wave, the P wave being atrial depolarization, the QRS complex representing ventricular depolarization as things move down the middle and around the outside, and the T wave representing ventricular repolarization, and then some funky bits sometimes come after as well. So in a 12-lead ECG, you have 10 physical leads, and then kind of the earth being one of the leads. 12 electrical leads, each one looking at the heart from a different angle. So the OSCE structure that you're going to use every single time for describing an ECG, and I want you to practice this until you're absolutely blue in the face and can do it in your sleep, is this. So you're going to start with the patient details, as you always do, and you're just going to say, this is a 12-lead ECG taken of Janice Brown. She's a 64-year-old woman, born on this date. This is the date it was taken. Bang, done. But make sure you say those things. The rate, one small square is 40 milliseconds, which makes one large square 200 milliseconds, which makes a whole strip on the bottom, the rhythm strip, 10 seconds. So the rate that you're going to tell the examiner is going to be 6 times the number of R waves that you see in the 10-second strip. It's as easy as that. Tachycardia and bradycardia, you know. You're going to look at the rhythm strip next, and you're going to say what rhythm it is. So whether it's regular or these horrible tongue twisters that get even worse when you're nervous, regularly irregular or irregularly irregular. That should be really easy to see from the rhythm. If it just looks all over the place, it's probably irregularly irregular. There's only 1 or 2 times where it would be the middle one, and we'll get into that now. Axis always used to confuse me a little bit until it got explained to me like this. So it represents the net effect of all of the action potentials that are going through the heart tissue. And to ascertain the axis, you need to look at the QRS complexes in the limb leads. So especially you're going to look at leads 1, 2, and 3. Normal axis is going to be the most positive in lead 2. So with the biggest QRS spike going upwards in lead 2. Should be between -30 degrees and +90 degrees, but that's not something you can really see on an ECG. Right axis deviation is most common in right ventricular hypertrophy. So you've got more right ventricle, basically, so more electrical signal to go through it. It looks the most positive in lead 3 and the flattest or most negative in lead 1. And finally, you've got left axis deviation, which is most common in conduction abnormalities. So lead 1 becomes the most positive, and that's what we've got on the right here. And leads 2 and 3 become negative. Hopefully that makes sense. So then we're going to move on to describing each waveform in turn. For P waves, it's pretty easy. Are they there? Are they not there? Do they look normal? So if they're present, then we're in sinus rhythm, and you can just say that. We'll get on to whether they're associated with QRS in a second when that section comes up. If they're absent, then we'll talk about that as well. But this is all you need to say for the P wave section. The PR interval you can calculate when you're in your silent time having a look. Normal is 3 to 5 small squares for a PR interval. So spike to spike, not include, as in Q doesn't count, it's spike to spike. If it's short, if it's prolonged, say it, or if it's normal. The QRS complex, you're going to look at its width and its shape. Its width is particularly important for tachycardias, which we'll come on to later. Normal is less than 3 small squares. Any more than that is a broad complex ECG. If it's got a funny shape, we'll start thinking about bundle branch block. And then there should be Q waves. The ST segment, look through all of the leads because things can be hiding in funny little places. It is normal for children to have some funny things going on with ST, so could be depressed. If it's normal, if it's depressed, if it's elevated, say that. And then finally, you're going to have a look at the QT interval. The machine, when you get the interpretation on the top, will usually calculate it for you. It's pretty useless otherwise, so don't read that for anything else other than the QT interval. It varies with heart rate, so it's given as corrected QT, QTC, different in men and women. Just remember that little one. And then there's an enormous list of drugs that can prolong it. That's supposed to say memorize, not memories. You don't need to memorize them, but do just double check for prolonged QTC, especially if they give you a funky medical history, especially a mental health history. So when you do psychiatry next year, there'll be a lot of ECGs to check for QTC prolongation, particularly SSRIs. The big hitter is citalopram. That's the one that makes your QTC go long, and antipsychotics. D waves, are they normal? Are they tented? So hyperkalemia, tented D waves. Are they inverted? Are they flattened? So hypokalemia would be the big cause of that. Look through all the leads again. In AVR, you would expect inverted T waves, so don't panic about that. So just to go back through, this is the structure you're going to use to describe every single ECG that you see. And you're going to practice this because the muscle memory is what's going to get you through what's a bit of a nervous time. Just basically describing whether each wave is normal, whether it's there in the first place, and storing stuff in your head for if it's not normal, what that could mean. So I'm going to now give you some time to have a look at this using the structure that we went through before. And start having to think about how you would describe this. So everything from patient details to what the waveforms say, everything like that. Just a minute to think about what you're seeing. Okay, if you've had a look at that, then don't worry at all if the structure doesn't come naturally at first. But I'm gonna go to the next. I'm gonna go to the next bit. So hopefully you've got 60 or 66 as the rate. Could be either, but about there. It's regular with a left axis deviation because lead 1 is the most positive out of all of them. Hopefully you can see that. He's in sinus rhythm because each QRS complex is associated with a P wave. There's a prolonged PR interval. The QRSs are quite narrow, definitely not broad. No ST segment changes, T wave flattening or inversion. So if you were to start to think about a diagnosis, then hopefully you'd at least start to think about something where potassium is involved. But the pathology is heart block. So that's kind of given away by the prolonged PR interval. So that was first degree heart block. Hopefully you've covered the different degrees before, but I'll just go over them again. So in each one, it is literally just a block of the heart going from the atria to the ventricles. So in first degree, it's not that difficult for it to get through. So the PR interval is just a bit prolonged, but it still happens every time and you're still in sinus rhythm. Second degree, that's when you start to move into an irregular rhythm. So Mobitz type 1 shows a Venkerbach phenomenon. The interval gets longer and longer and longer until you drop a P wave. So you'll see that regularly irregular. Sorry, I've got that wrong. That irregularly irregular pattern. So it gets longer and longer and longer, and then you see a missing P wave, and that's the Venkerbach phenomenon. With Mobitz type 2, the blocks are just all over the place. It might be 2 and then a drop, or 3 and then a drop, or 4 and then a drop. And with third degree, it's a complete heart block. So the P waves are present, but they're completely just random, not associated with QRS complexes. So the atria and the ventricles are kind of just doing their own thing. So that's showing you the prolonged PR interval, which is what this first case had. This is the Venkerbach phenomenon. And hopefully you can see it's kind of got 3, then a drop, then yeah. And here we've got those sporadic Mobitz type 2 blocks. And then complete heart block where you've got some PR wave, some P waves, but they don't really mean any, they're not causing the QRS complexes. That's the thing to look for. So case 2, have a look at this and decide what you think is going on, decide how you would describe it. Also, if anyone does want to turn their mic on and have a go, then please do feel free. Oh, sorry. Okie dokie. So Sylvia Thorpe has this. So she's tachycardic, which I hope you can see, with a rate of about 132 beats per minute. It's irregularly irregular with a right axis deviation. She's not got any P waves as far as I can see, no little humps before the QRS complexes. The QRS complexes are narrow. So this is a narrow complex tachycardia. No ST segment changes and normal T waves. So hopefully the phrase irregularly irregular to you means something, especially when it's fast and the person's experiencing palpitations. You might not have actually seen it yet, but I hope that those words will mean something, because this is very common. This is atrial fibrillation. So you've got this classic irregular rhythm. The P waves are absent, and that is pathognomic for atrial fibrillation, those two things together. The rate can be fast, the rate can be normal. You'd be more worried about fast AF, but both aren't great, especially because that's when you need to start thinking about anticoagulation, because they're then at risk for ischemic events, strokes, coronary events, PEs, the works. So yeah, not good. Case 3, Diane Yang.
Can you hear me?
Sorry?
In the chat, if you could explain why it's a right axis deviation.
Oh, sorry, I can't see the chat. Maybe I'm going crazy. Yeah, if there's any other questions, could you say them out loud? Because I can't get the chat open. Where are we going back to? Is in here?
Yeah, I assume then.
Yes, please. Yeah.
Yeah. So mainly because 2 should be very much more positive than 3. If 3 is roughly equal to, I can see why you'd go normal. And to be honest, yeah, I mean, you could go for either. It's a very minor right axis deviation. The main thing just being that you should really see a big clear difference between 2 and 3, which I don't think is really here. It's open to interpretation. Hopefully that helps.
Great, thank you.
So does that clear that one up before I move on?
Yes.
Cool. Right, atrial fibrillation, we covered. Case 3, have a look at that for me. Have a look at the age as well, might tell you something. Okie dokie. So here we've got Diane Yang. Her rate is 72 beats per minute, which is normal. It's regular. She's got a left axis deviation. P waves are present, so she's in sinus rhythm with a normal PR interval, broad abnormal QRS, ST elevation, which I really hope you can see in V1 to V4, and normal T waves, which can be difficult to see when ST is so different. But if you look at the rhythm strip, then that should help you. So this is right bundle branch block. Sorry, this is bundle branch block. So right bundle branch block is normal in some people, abnormal in others. Left bundle branch block is always pathological, which is a question that does come up in multiple choice, always, often due to previous ischemic events. When there is bundle branch block, something that's really good to say in front of the examiner is you can't go any further into your, waveform analysis. You can't reliably interpret the ST segment or the T waves. So this does not mean there's a STEMI despite the ST elevation. And we'll get into why it's one and not the other. So I always find this really difficult to see, but this is what they tell you. So left bundle branch block allegedly looks like a W in V1 and an M in V6. So that's why it says William, because WLLM. The QRS is broad, as it is for right bundle branch block, which is the marrow part of William marrow, an M pattern in V1, which you can see here, and a W in V6. I think every single time I've tried to guess whether it's an M or a W, I've got it wrong. I can't see the M or the W, but if you can, then I'm happy for you. But this is what everyone tells you, so good to at least heard of this, and good to at least show that you're trying to use it when it comes up. I think it's very unlikely that they will ask you to determine whether it's a left or right bundle branch block. Case 4.
Can I ask a basic question about that case 3? Can you just
Of course, yeah.
for me? I was just really struggling to see them.
Sorry, say that again.
Can you point out the P waves? I was just struggling to see them.
Yes, they are. Can you see my mouse?
For the previous one, ECG. Yeah, that one.
Yeah, here. Can you see here?
Okay.
Yeah. So that is the P wave, and it's before every zigzag.
Okay, thank you. So you only look at the rhythm strip to see if the P wave is present.
I'm a big rhythm strip fan. If you see it anywhere, it's probably there. So I always look to the rhythm strip first because it's the most obvious and the longest. If you see it anywhere, it's there.
Yeah, great, thank you.
Cool. The rhythm strip is especially good for P waves and T waves. Cool. Okay, case 4, have another look, decide what you think you're seeing, and maybe practice saying it out loud as well. Okay, so this is Mohammed. He's got chest pain. He has a rate of 78 beats per minute. It's regular. There's left axis deviation. The P waves are present, so he's in sinus rhythm. The PR interval is normal. The QRS complexes are normal, narrow. There are Q waves. There is ST elevation in the following leads: 1 AVL and V1 to V5, and normal T waves, which it can be difficult to see. But hopefully, again, you can see that in the rhythm strip, like I mentioned before. So Mohammed is having a bad day. He's having a myocardial infarction. He's having a STEMI. So STEMI involves new ST elevation or new left bundle branch block, which is kind of what I said before. There are Q waves. You might see T wave inversion as well. It'll definitely be inverted in comparison to the ST elevation. NSTEMI, ST depression or no kind of ST changes, it's just non-ST elevation. Q waves, again, T wave inversion. And like I said before, some ST depression in children can be normal. So if you get a sick 9-year-old with ST depression, don't go saying that they're having an NSTEMI. Okay. This really helped me when I started to memorize this. So this is the segments of the ECG that you will see abnormal. So you'll see the ST elevation in when you think about what part of the heart the infarction is in. So yeah, just have a look at this for a second. Definitely go away and learn this in your own time because it comes up time after time after time. And once you've got it, it's really easy. So V1 to V4 is going to be an anteroseptal STEMI. And that's caused by the LAD being infarcted usually. Inferior STEMIs are shown in 2, 3 and AVF and caused by the right circumflex artery usually. Hopefully you'll remember that some people have slightly different circumflex artery anatomy and it will be different for those. And then lateral STEMIs are shown in 1 AVL and V5 to V6. And that's usually the left circumflex artery, but again, slightly different in some people. There are no leads that look at the posterior heart, but obviously it can infarct like every other bit of the heart. So a posterior MI can be seen in the anterior leads as the opposite of a STEMI. It is literally the reverse. So you'll get this ST depression, real upright spiky T waves, and a prominent R wave with a possible inverted Q. This isn't the sort of thing that they'll ask you, but it's good to know, especially if someone says, you know, what are some differentials for ST depression, or how would you know if they'd had a posterior STEMI? If there aren't any questions, I'll just keep trundling along. Hopefully this won't take you long. It's difficult to describe this one because there's a lot of wiggles. You might know what this is, you might not, but give it a go. I'll give you kind of 20 seconds-ish. She's collapsed, by the way, if that helps. So Annabelle Terran is also not having a great day. Her rate is 162 beats per minute. Again, don't freak out if you see this sort of thing. With this structure, you can at least start to describe it because it looks terrifying, but give it a go. The rate is 162 beats per minute, so she's tachycardic. The rate is regular, unable to assess the axis because there are no clear QRS complexes that you know mean anything. The P waves are absent, the QRS is very broad, can't assess the ST segment, and neither can you assess the T waves. So we're going to talk about tachycardias. They can be a bit tricky, but once you get your head around them, it's fine. So we're going to separate them into narrow complex and broad complex. Narrow complex tachycardias arise above the ventricles, and then the conduction can still pass down the bundle of His. So examples are sinus tachy, which is what came up in our OSCE last year. I spent my whole time looking for something really niche and clever, and it was literally sinus tachycardia. AF, atrial flutter, SVT, that sort of thing. Broad complex, pretty much always worse. They arise in the ventricles. The exception is if you have a bundle branch block and also have tachycardia. So you've got a bundle branch block and you've, for some reason, been for a run. Examples are VT and VF. So sinus tachycardia looks like this. Everything's regular, narrow complex, fine. There are P waves, happy days. They've probably just been on a run or, you know, something else that would get your heart rate up. Yeah. SVT, P waves are absent. Crucially, it looks a bit like sinus tachy, but the P waves are not there, which is crucial. Atrial flutter has this sawtooth baseline, which is a good word to use. You do get QRSs conducted, but only every so often, which you can see here. Ventricular tachycardia is what Annabelle had in our earlier STEM. It's broad complex tachycardia and it's regular, but it looks like a nightmare. And then ventricular fibrillation, you're having a really bad day. It's just wiggles. There's not much. You can explain it using your structure, which will gain you a lot of marks because there's really not that much else to say. Oh, sorry, I just realized I'd missed a message. Hopefully that's been sorted now. Okay, if anyone has any questions before chest x-rays, I know that was a whistle-stop tour. Please speak now. Or put them in the chat. And if not, I will move on. Awesome. Okay, I'll keep going. And then if you have any questions, just speak up. So what we've covered so far, is this structured approach, which you should be using absolutely every time, no exceptions, and it will get you so much further and makes you look so much more with it. Possible abnormalities of rate, axis, and waveform, and then those 5 common abnormalities that we just covered. And hopefully those are a bit clearer now as well. Please, could you give me feedback for that little ECG session, and then we'll move on to the chest x-rays. And I'm just going to have a drink of water.
Sorry, has the screen moved on for everyone else?
Pardon, sorry?
The screen hasn't moved on for me, but I don't know if that's a problem from my end.
Oh, weird.
It looks like it is. I'll just rejoin.
Okay. This is just because the sessions are kind of separate. So just so I know what's good from each one and what needs working. I'll give you kind of 2 minutes to do that, and then we'll rattle straight on. Chest x-rays is a bit longer. Okie dokie. Hopefully we're all good. If not, just shout and I'll give you more time. Yeah, the ECG Made It Easy is a really, really, really good book or resource, sorry, use that. Obviously I use Geeky Medics as well, and then some teaching that we got last year was really helpful for this as well. So we're going to move on to chest x-rays, which I find harder than ECGs just because I'm not particularly visual. I'm not sure what's artifact and what's not, but hopefully this will help. So again, same learning objectives. We're going to use a structured approach to reading them. We're going to learn to recognize abnormalities, and we're going to link those with conditions that we're going to see all over the place, the really, really common ones, MCQs or skis, any medical placement that you're ever on. So OSCE structure for describing a chest x-ray. Hopefully a bit of this is familiar. So we're going to do the patient details. So name, date of birth, age as well, I guess, date taken, and then the presenting complaint if you know it. So exact same as ECGs. Hopefully you'll be in the swing of that. Film details, AP or PA, front to back or back to front. AP is the normal way. PA, if you get that, it does some funny things, might make the heart look really weird. It's just good to know. Whether they're supine or erect. So for example, if they're erect, standing up, then if you see a really funny kind of straight line at the bottom, then you'd be thinking fluid, because that's where things are going to collect with gravity. You might not see that if the patient is supine because it'll all be at the back. And then what the x-ray is of. The quality of the film, hopefully you'll know right. So rotation are the medial ends of the clavicles equally spaced from the spinous processes, or do they look twisted? Inspiration, can you see 5 to 7 anterior ribs? So the anterior ribs are the ones that point downwards in the middle. That's how you don't confuse them with the back ones. Penetration, can you see the spine behind the heart? If you can't, then the penetration's not good enough. And exposure, can you see all the way to the shoulders, so all the way to the apices and all the way down to the costophrenic angles? If you can't, then the exposure is not good enough. Good. Okay, so we've got 7 key structures here, all of which you're going to have a look at. So if we think about the way the air goes in, it's a good start. So we're going to look at the trachea and the bronchi, the hilar of the lungs, the heart, obviously, the diaphragm. This is normal. The left diaphragm commonly sits a little bit lower down. The pleura, so all the way up around the edges, that's where especially you'll be having a look for pneumothoraces. The lungs themselves and the bones at the top. A really, really key one to look for is the clavicles. It gets missed every time, but in our OSCE last year, the ECG was sinus tachycardia and the chest X-ray was a pneumothorax. So obviously the two made sense to go together. And I think it was a crazy percentage of our year, like 90% of our year missed the fact that the ipsilateral collarbone was broken, and that was the cause for the hole in the lung. So always good to have a look at that as well. So as I just said, review some areas that have kind of hide these abnormalities. Go back and check behind the heart, at the top of the lungs, at the lung apices, under the diaphragm and the clavicles. So for example, here when you check under the diaphragm, not good. Air under the diaphragm, not a good thing. Air a bit lower than that is fine because that could be in the stomach, but air right here is not good. We're thinking bowel perforation for this if there's free air just passing about in the abdomen. So a good little tree to help you decide what's abnormal in the lung. You can just have a look at this one for a second and then go back over this in your own time. We'll be covering 11 of these today. Okay. So case one is pneumonia. This should show you air bronchograms. So these are air-filled bronchi on secretion-filled alveoli. So patent bronchi, but with kind of liquidy filled alveoli. So that's the classic consolidation picture where you've got all of these lines. These are the bronchi, but they're showing up really clearly because the alveoli are full of liquid. Yeah. So the shadowing and opacification is very commonly combined by the fissures. So you've got this really clear line here, and that's because that's where the lobe of the lung ends and starts. And it can look like lobar collapse, but the volume loss is minimal compared to lobar collapse. As a reminder, these are the lobes of the lung, different from lung to lung. Obviously, we've only got 2 here, we've got 3 here. If you're unsure, please, please, please do not try to guess which lobe a pathology is confined to. If you don't know, don't say it. That's like, for some reason, that seems to be these examiners' pet peeves. If you kind of say, oh, it's in the middle lobe of the lung and it's not. Really easy and just as good to say a zone of the lung. So upper left lung is fine and a lot more easy to be right, especially if the patient's at a funny angle and all that stuff.
Sorry, can I just ask,
Mhm.
in the first image,
Yeah.
it might just be me, but is the rotation slightly off or is it normal?
Yeah, I completely agree with you. I think the rotation's off as well. That's a good
Okay.
spot.
Okay,
Yeah,
thank you.
especially like a really good way to look at it is the clavicles. They just don't look symmetrical.
Thank you.
But realistically, none of the chest rays are actually going to be perfect. So it's good to just say that you think the rotation's off because patients wriggle. Okay, so as a reminder, this is what you're going to look for medically to give you a high suspicion of pneumonia. So confusion, urea, high resp rate, a low blood pressure, and old age. I think this was really helpful for me when I found this out because it used to come up all the time and I was always really confused. Pneumonia in an alcoholic think Klebsiella, pneumonia and COPD, think Haemophilus influenzae, and the most common pneumonia by far is Streptococcus pneumonia. So atypical pathogens that might cause consolidation on both sides. So if you're seeing what looks like a bilateral pneumonia, which is confusing because that really shouldn't be the case, think immunocompromised people with atypical pathogens. Might not be everyone, it's just a thought if it's bilateral. So you've got Legionella, which is the classic, like, went on holiday to Spain or went on a cruise ship and used a dirty water fountain and has come back with SIADH, LFTs all over the shop. And to test for that, you should test with a urine test. So that's a good extra investigation to do. Mycoplasma, you'll get this autoimmune hemolytic anemia, erythema multiforme, neurosymptoms, and you can use serology, blood serology, to test for that. Viral pneumonia is a bit more likely to be bilateral, so COVID, flu, and then fungi in immunocompromised patients, such as HIV patients. Okay, case 2. We've got a pleural effusion. It shows the meniscus sign. So hopefully you can see around here, it's some real blunting of the costophrenic angles, which should be super sharp, should be really pointy, but they're not, they're rounded, and that's because of the fluid. And that's why I said it's really important to look for whether or not the patient is erect, because if they were lying down, you wouldn't expect this blunting, but they could still have a pleural effusion. They should always be standing up unless there's a reason for them not to be. The loss of that hemidiaphragm border, it kind of appears raised and a bit funny, and it's all just a bit white and horrible. I would say the exposure of this, the penetration of this probably isn't great anyway, but yeah, you can see that blunting. You may even get mediastinal shift to the opposite side if the effusion is large. And in order for it to even be seen on chest x-ray in the first place, you need at least 200 milliliters of fluid. So it might be that you have a small pleural effusion and it's not seen on chest x-ray. Think about the underlying pathology. This comes up all the time as well. So heart failure, infection, cancer. You'll be able to determine the cause with a pleural tap and then analysing what's in the pleural tap. So you'll get transudate or exudate. Transudate happens because the hydrostatic pressure is increased or the plasma oncotic pressure is decreased. And then I always think of the kind of transudative things as the ones where the lungs are really struggling and kind of slowing down and just all blocked up and boggy and horrible. Exudate kind of happens when something is like really stressing the lungs out, like right now. So pneumonia, cancer, TB, that sort of thing. You've got a lot of protein and LDH in that because it's all forcing through the walls. And then you use light criteria if it looks somewhere in the middle. Any questions on that? Cool. So case 3 is a pneumothorax. And I don't know if you can see, but I also think that this patient probably has some other things going on because I can see a whole lot of ribs here. Tip, as I said before, check for a fractured clavicle ipsilaterally, or check for literally something in the chest wall or just anything that might have caused it. They're often spontaneous, but probably good not to miss the thing that has caused a hole in the lung if there is one. So the affected side will look darker because of the loss of lung volume. And I hope you can see here, it's faint, but you should always, always, always look for it, is this line here, and that's the edge of the lung. You can see that it's a different shade to out here. There's no clear kind of pleura around here. It's all here. There's no lung markings, no nothing. And if the visible lung edge is 2.5 centimeters away from the chest wall, then you've lost 30% of lung volume. It's measured from up here. So chest wall to lung apex, small is below 2 centimeters and large is above. After pneumothorax, advice to give the patient no smoking, no flying until they've had their review chest x-ray after they've got better, and no more scuba diving. For some reason, they in MCQ land, they're all very keen scuba divers, but they need to stop. Okay, Causes of pneumothorax, primary is the most common. In a question stem, it will say a really lanky, tall, often Caucasian, 20-ish-year-old man who comes in really short of breath all of a sudden, probably a spontaneous pneumothorax. And then you've got these other reasons as well. It makes sense, anything that would cause the lung stress over a period of time. So tension pneumothorax is the kind of subset of this, and you should never ever see this on a chest x-ray because they should never have made it to the scanner in the first place. They should have been decompressed before they've made it to the scanner, because this is an emergency. You'll do this in 5th year in autumn, where you learn how to do a needle decompression. So that's a needle or finger thoracostomy. I accidentally said thoracotomy in my OSCE, which means cracking the whole chest open. I didn't mean it. The classic literature says the second intercostal space at the mid-clavicular line. That's actually really changing to the triangle of safety, which is the 4th to 5th intercostal space at the mid-axillary line, just because it works better for a variety of different body habitus. And it just generally is safe. You're less likely to hit an important structure. You'll practice this next year. If it's a tension pneumothorax, you will see mediastinal shift, which is what we've got here. So very clear. I think the lung's coming in at around here. It's all bunched up. That's where the lung markings end. So a huge loss of lung volume here, and all of this air with every single breath is pushing and pushing and pushing. So we've pushed the heart right over here, and you've still got those lung markings here. That's how you know that that's not the affected lung. A heart failure can be tricky. There's an A, B, C, D, E for signs of heart failure on chest x-ray. So you've got these alveolar or bat swing edema signs. I have no idea what that really means, but you learn to look for it. A curly B line used to really confuse me. So it's really tiny and you can't see it very well at all, ever, pretty much. But if you look at the chest wall, particularly towards the bottom, and then look for these horizontal lines, these really small, thin ones that kind of protrude straight out. I don't know if you can see very well, but that is a curly B line. There's one here as well. And that's a really good indicator of heart failure. There's no real other reason for that. Cardiomegaly, you'll get a massive heart, obviously. Upper lobe diversion, hard to see as well, but things just getting pushed all over the shot. And these bilateral effusions, again, so pleural effusion, blunting of the costophrenic angle. So even once you've gone in and seen this massive, great big whopping heart, you still need to look for all of those things systematically, because this is something to not miss. Cardiomegaly is defined as a cardiac silhouette, which takes up over 50% of the transverse chest diameter. We're going to start the patient on ACE inhibitors, beta blockers, and a whole load of other stuff probably. And we're going to do an ECG, a BMP, and an echocardiogram. Case 5, lobar collapse. So different bits of the lung can collapse at any one time. Can be trauma related, often infection related, can look similar, I guess, to lobar pneumonia, but it's different because it's kind of this whiteness, this kind of confluent opacity rather than the consolidation. So you've got this volume loss, the hilar and the fissures get pulled upwards towards the collapse, and the heart and hemidiaphragm borders often look normal. This is a right upper lobe one, but each lobar collapse looks different. If you think about it disappearing and then every other structure kind of being pulled towards it to fill the space, because the thoracic pressure tries to stay as normal as possible. So for example, if you have one over here, you might get the heart being pulled in that direction. Yeah. Case 6 is a misplaced NG tube. They'll often show you silly things like this, and just it's good to get to grips with what's normal and what's not. I hope that you can see that this person also has a bunch of wires on them. Yeah. So a normal NG tube should go straight down in a straight line down the whole esophagus to below the diaphragm and then into the stomach where there should be a gas bubble. So you should know what that looks like. Here, it's gone all curvy. It's very clearly kind of followed the tube of the left main bronchus and then ended above the diaphragm, which is bad, obviously. We often do chest x-rays after NG placement to stop aspiration pneumonia, which should never ever be happening. Sometimes they'll just take the pH of the aspirate up from the NG tube, and if it's very acidic, then they know it's stomach, and if it's not, then it's probably in the wrong place. But that's really only for experienced people. Chest x-rays are very common for this. The tube is radio opaque for that reason. Yeah, this person's, yeah, that's not good. This is quite an extreme example of lung nodules or masses. But yeah, please sit and have a go at describing this yourself with its own mini structure as to how you would describe a nodule or mass. Okay, hopefully you've had enough time to have a go at that. So that's how I would describe it. Obviously, you can do it in different ways, whichever makes sense to you, but those are the key bits to get to grips with. I mean, they're the key ways of describing any nodule or mass that you see anywhere. But that's a good structure a good kind of side structure to familiarize yourself with. So here we can see multiple bilateral, well circumscribed round opacities or nodules. This is in keeping with cannonball metastases, which are often seen in renal cell cancer, testicular cancer, GI, thyroid, breast cancer. I've just seen. How would you know how big the nodules are? Sometimes they'll have a clear scale on the bottom. If not, then maybe don't give an exact kind of size. Just say, like, I would say that these are large. You can kind of give them in relation to what you can see. So if they're taking up half the lung, then say that, or if they're teeny tiny, then say that as well. But yeah, you don't necessarily need an exact number of centimeters. I hope that helps. COPD, this is kind of what I was getting at earlier with that pneumothorax one as well, because this chest is really hyperinflated. Both lungs look really dark, which could also be an artifact. So make sure to kind of have a look at other bits to see whether you think the penetration is good enough. The diaphragms are flat. If you look, they're not rounded like they should be. So you've got this real kind of barrel chest person that you see on inspection, really struggling for breath because it just looks like there's always too much air in their lungs. A good way to quantify this is to know that there are over 7 anterior ribs. So these are the ones that kind of point downwards in the middle. Yeah. But yeah, far too many ribs here. It just looks really hyperexpanded and really uncomfortable. Pleural plaques, a bit more rare, but I have seen it come up. Thickened pleura due to asbestos exposure. You get these kind of patchy or map-like appearance with really well-defined edges, and you can just see that the edges of the lungs just look really white, really thick. The lungs also look quite small here. They might be calcified, and they're not kind of confined to fissures or lobes. It's the whole lung. just quickly, if you see one lung that looks darker than the other, so here I would have said this lung is darker, just have a quick look for breasts, especially, yeah, if there's only one, check for breast shadows, and yeah, just don't be someone that thinks that there's consolidation when it's actually just a breast. Just quickly, I'll mention whiteout. So it can look really scary when you get presented with this, but there's a good structure to think about it. If you've got mediastinal shift and it's towards the white lung, then either they've had a whole lung taken out, so pneumonectomy, or the whole lung has collapsed. Either way, they've only got one lung. If the mediastinal shift is away from the white lung, it's full of fluid. So a large pleural effusion or a massive hemothorax. If there is no mediastinal shift, then we'd be more thinking whole lung pneumonia, but that's very rare and more common in immunocompromised people. So that's a good structure to think about that. So just to go back over, every time you talk about a chest X-ray, you're going to give the patient details, the film details, go through RIPE to discuss the quality of the film before you go anywhere else. You're going to go through these key structures, which are on the right here, in the direction that air might go. So, or at least that's the way I think of it, kind of moving along. So the trachea and the bronchi, the hilar, the heart and the mediastinum, the diaphragm and the costophrenic angles. Then you're going to work your way up to the pleura, the whole lungs, the ribs, and then those cheeky little review areas. So the very tops of the lungs, behind the heart, the very bottom below the diaphragm and the clavicles. And then you shouldn't miss anything. If you don't get all the way through that, then that's fine. There's a lot to remember. But at least kind of a bit like a driving test, at least showing that you're looking at each section and looking properly for the borders of everything is going to be really important. Does anyone have any questions? Okay, if not, then I'm going to just reiterate what we've covered, and then I'm going to ask you for feedback again. And then I'll be sending the slides out tonight once you've replied to this. So you've got 2 minutes to do that. And then if no one has any questions, we're done, which is good timing. But please, please, please just go away and practice this on your own. This is not like you'll need to go away and practice this. It's okay. Yeah, I hope you all have a good week and that exam prep is going well, and we'll see you again next week.